cataract, other problems. And so, considering that cataract is such a fast and clean and neat and clean surgery with hardly any blood visible, and it just takes 10-15 minutes these days. So people avoid VCR, but with the right instrument related to the nasal anatomy and where we have to make the opening. So as we can see here, this is the area where the lacrimal sac and the naso, you have to make the opening or the ostium from the lacrimal sac into the middle meatus. So most of our seniors were also very conversant with lacrimal procedures, because earlier this was taught very well in medical colleges. Now it is probably not something that is that commonly taught. So this is just a review of the anatomy so that we know where we are working and its relation to the nose. And also this is the area, this is the lacrimal fossa, which is, as we know, formed by the maxillary bone anteriorly and the lacrimal bone posteriorly. This is the maxillolacrimal suture where we initiate our opening when we are making the bony ostium. And the lacrimal bone, of course, is the thinner part which we can easily remove to create the bony ostium. So when it comes to sac surgeries, you can have external approach or the endonasal approach or the canalicular approach, then there are implants. Then surgical and laser approaches to osteotomy. There was a time in between when laser bony openings were being created using holmium Layag laser or KTP laser and other such lasers, but they didn't really become popular because the bony opening was not very good. So we are back to external DCR or endonasal mechanical DCR. Dacrocystectomy, which was earlier done much more, still has some role in very elderly sick patients as a palliative measure. If you have an infected sac, a big sac, you don't want to do an extensive surgery like bony opening, you can just remove the sac and it still has a role. The advantages of endonasal DCR that we talk about are that there is no external scar. So it is a very good marketing thing because you tell everyone that there is no external scar. So it is very good because you can see where the adhesions are. You can remove the adhesions under direct observation with the endoscope. It does take less surgical time in experienced hands as compared to external DCR, but you have to have many years of experience to reach that stage. There is less hemorrhage. And it can also be done in cases of acute dacryocystitis. Sometimes you have to operate in cases of recurrent acute dacryocystitis that is not resolving. In those cases, the disadvantages and high cost of equipment and maintenance, and also the learning curve for ophthalmologists is very steep. Not all ophthalmologists can learn to use endoscopes and operate while they are looking at the television monitor. And also, if you have like common canalicular block and you do things like pericanalicular dissection, these cannot be done through the endonasal route. Many surgeons even now prefer GA for endonasal surgeries, and sometimes you obviously, with all the practical problems, you need two surgeons, an ophthalmologist and an ENT person. Or you have to refer to the ENT people, but even they sometimes want to call the ophthalmologist. So external DCR is something that is time tested. It has the best reported success rates even today. Any study that you will read on the comparison of external versus endonasal DCR will only conclude that endonasal DCR has as good success rates as external rates, never better. You can create a large osteotomy, large bony opening in external DCR and a duration of cosmetic significance of external DCR scars based on a survey of almost 500-600 cases of external DCR. So as you can see in this picture, this is an Indian patient in our practice. The scar is not really very conspicuous in this area, and because this is such a vascular area, the scars heal very well, and cosmetically it is not much of a problem in that depression near the medial canthus. If you do make your good incision, good suturing, unless the patient has some sort of skin pathology or a keloid formation tendency or something, the scars are not really much of a problem. And whatever little scar is in, this is immediately at the end of the surgery, and 3 to 6 months this will be barely visible. So for external DCR, first of all, preoperatively we have to rule out any associated conditions, because many a times there can be a small medial ectropion which is missed, and if it is just watering, the patient may continue to have watering after the surgery and will not be satisfied. So always look carefully for the lid positions, whether there is an associated lid malposition, particularly small medial ectropion. Explain to the patient very well that there may be some streaking of blood through the nose, through the nasal fluids after the DCR for 2-3 days. And we must do a basic nasal examination in the OPD so that we don't miss a large polyp or a grossly deviated nasal septum or something. Good sedation is always good. We have been doing in our residency, because DCR is not very, doesn't take much preference in surgical hierarchy. So, but you must get good sedation. That will always make you and the patient very comfortable. And I think the doctors and the surgeon's comfort is more important here. And good nasal packing and block, and also investigations, which we all know, bleeding time, clotting time, etc. So that there is no bleeding tendency that we miss. Now these are some pictures for endonasal DCR. This, as of now, in most places in India, it is still in the field of ENT surgeons. Most ophthalmologists in big centers have just started doing. There are only few centers where the ophthalmologists do endonasal DCRs. Otherwise, it is still mostly ENT surgeons doing. But it is still good to know basic pathology and have some sort of an understanding of what the endonasal view looks like. So this is the septum, this is the middle terminate, this is the inferior terminate. This, once you fill the lacrimal sac with this line, you can fill it and it becomes more visible. This is the middle terminate. This, as I said, is the area where you want to make your opening. Here, this is the exposed lacrimal bone area, and you use these kerosene rongers to remove the bone. So, if you see more pictures or you see endoscopes, at least you will have some idea. This will also help you to understand what you are doing when you are doing an external DCR also. Then coming to anesthesia, we know we have to give an infratrochlear nerve block, which is the most important, and also local subcutaneous infiltration, where we will be giving the incision. Also change the direction of the needle, inject right up to the periosteum also, because you will be working very near the bone and removing and reflecting the periosteum. Earlier people used to use a peri-infraorbital anesthesia somewhere here, but it is not really required and also not very commonly used these days. And the infratrochlear nerve block, it is described as you should give in the superior medial orbit. One of the things is you just palpate the medial canthal tendon and just go slightly above it, but don't go very deep, or you may go near the anterior ethmoidal foramen, or you may not really anterior ethmoidal foramen, that is very posterior, but just go above the medial canthal ligament and go slightly deep, where you will give good anesthesia. This is the area. So superior medial orbit, just above the MCT for the infratrochlear nerve block, and also good local infiltration. Now this is, I don't know if the video will work in this. Okay, just a second. Actually, the audio visual person is not here, so I'll have to go back to the, go back and show the video separately. Just a second. Okay, so this is nasal packing. And nasal packing, what is described in books is that you use cocaine. Cocaine is not easily available, so you have to use a sort of a cocktail. 10% xylocaine spray that is used by ENT people is easily available. You also use 10% xylocaine spray. Oxymetazoline, that is the normal nasal drops that we use, Nazivion, etc. As well as your xylocaine with adrenaline 2% that you use for the nerve block also. And then make sure that you have this good long bladed nasal speculum, and you put your pack, like I've been emphasizing, you have to know that you have to pack that middle meatus area where you will be making the Bosnia opening. Often we are very hesitant and we just pack somewhere near the inferior meatus. That won't work, so go deep enough to be near the middle meatus. And this cocktail of 10% xylocaine with oxymetazoline with xylocaine adrenaline works almost as good as cocaine. Cocaine is available in the West, but the results are almost similar, so nothing too much. We can use this here. Then when it comes to the steps of DCR, the first is the skin incision. It can be straight or curved. Theoretically, curved may lead to webbing. Webbing meaning that your medial canthus area, there can be some sort of a fold. So because the skin is very thin, so if you go in the slightly thicker of a DCR, of course this is edited, so it looks very fast. It is never so conveniently fast in real life. So this is the skin incision. The skin incision, which I usually have, is like about 10 millimeters from this corner of the medial canthus. Then this is artery. Once you have too much blood, it may become a little difficult to see this accurately. So this is this that I have used here is the right angle instrument into the maxillolacrimal fossa, and then you use that right angle to separate the nasal mucosa from the bone. And then after you've made the bony ostium, you can insert an instrument through the nose. This is the instrument through the nose. This is the nasal mucosa that is shown. You can press it with the instrument that you have inserted through the nose, and then suture the mucosal and the sac flap. And then if you want, suture the orbicularis, and then suture the skin incision. And the skin scar will not be very conspicuous, and then do a post-op solution at the end of the suture. So there can obviously be failure or anastomotic closure. The other things that add to comfort, apart from good equipment, is that you always have a suction catheter at hand. Either you use so see, this is how you have to make it like a hockey stick, so that it goes smoothly. And then you go through the inferior lower punctum. I'm going here. You use an artery forceps to pull it out once you have. It's a long probe, so once you know you are near the junction of the probe and the tube, you go very carefully so that you don't disinsert, and then you put your curved artery forceps through the nose, and you just feed the silicone tube into the artery forceps. This is the other end of the silicone tube, and pull it out through the nose. You can cut the probes at this time if you want, or so that they don't injure your nasal cavity. And then after you've got these two ends of the tube, you can suture the mucosal flaps, and then just knot the two ends of the silicone tube and 3-4 knots so that it doesn't slip off. So this is the content of the canaliculus, and it also depends on whether it is proximal, meaning very near to the medial canthus. So here, this is the neophlon tube. This has come through the punctum and going into the other end of the content of the canaliculus. And once you approximate the two cut ends of the canaliculus, your lid apposition will be perfect. There is absolutely no question